Hudson.
Here.
Senator Carter.
Here.
Senator Nicola.
Here.
Senator Lewis. Senator Nurnberg.
Great.
Everybody's present.
Thank you. I make the motion that we go to executive session. Can I get a second?
Second.
Thank you. I make a motion that we bring Senate Bill 878 relating to the duties of a pharmacist before the body. Can I get a second?
Second.
Thank you. Senate Bill 878 is before the body. Is there a Senate committee substitute ending in, there is one, ending in .03 C. Is there any discussion on the substitute? Did we have those? You should have got them in your email box, but
I probably did. I do apologize. What's the, I know I've had several discussions. Can you kind of explain just kind of the brief summary of this?
so this is relating to the duties. This is the bill that we heard from Senator Fitzwater a couple weeks ago in relation to the keeping in place some of the responsibilities that the pharmacists had prior to COVID.
I did have a conversation on what the changes were, so I apologize.
No worries.
I slept and forgot what I had my conversations on. Thank you.
It's all good. We're getting all of us are getting our bearings this morning. All right, any further discussion? Seeing none, I move to adopt Senate Committee Substitute for Senate Bill 878. Can I get a second? Thank you. All in favor?
Aye.
All right, I make a motion to do pass for Senate Bill 878. Can I get a second? Thank you. Senator Secretary, please call the roll.
Senator Bratton. Senator Hudson. Senator Nicola.
Aye.
Senator Nurnberg. Senator Lewis. Senator Carter.
Aye. All right. That was unanimous, 6-0. Thank you. I now make a motion that we go to bring Senate Bill 970 related to cost sharing under the health benefit plans before the body. Can I get a second? Thank you. Senate Bill 970 is before the body. There is a Senate committee substitute ending in .02C. Is there any discussion related to that? All right. Seeing none? Okay, thank you.
I'm just, excuse me, Madam Chair, I don't think I have a sub. Oh, actually, never mind.
Okay. All right, great. Any further discussion? I now move to adopt Senate Committee Substitute for Senate Bill 970. Can I get a second? Thank you. All in favor? I move to do pass Senate Committee Substitute for Senate Bill 970. Can I get a second?
Second.
Thank you. Secretary, call the roll.
Senator Bratton. Senator Hudson. Senator Nicola. Senator Nurnberg. Senator Lewis. Senator Carter.
Aye.
Vote 4-2.
By your vote of 4-2, Senate Bill 970 has passed. Now I make a motion that we bring up Senate Bill 887 relating to Lyme disease before the body. Can I get a second?
Second.
Thank you. Senate Bill 887 is before the body. Is there any discussion?
Senator Lewis.
Just to, there was no sub on this. Okay.
No.
All
It's
right.
just what was presented initially.
Okay.
By Senator Schroer.
Yep, thank you.
Yep. I make a motion that we do pass Senate Bill 887. Can I get a second?
Second.
Thank you. Secretary, call the roll.
Senator Bratton. Senator Hudson. Senator Nicola. Senator Nurnberg. Senator Lewis. Senator Carter.
Yes.
Vote of 5-1.
With your vote of 5-1, Senate Bill 887 is due pass. Now I make a motion to bring Senate Bill 999 related to abortion before the body. Can I get a second?
Second.
Thank you. Senate Bill 999 is before the body. Is there any discussion? Thank you. I make a motion that we do pass Senate Bill 999. Can I get a second?
Second.
Secretary, please call the roll.
Senator Bratton. Senator Hudson. Senator Nicola. Senator Nurnberg. Senator Lewis. Senator Carter.
Aye.
Vote of 4-2.
By your vote of 4-2, Senate Bill 999 has passed. I make a motion now that we exit executive session. Can I get a second?
Second.
Thank you. We are now out of executive session, and we will begin with Did you put these in order? Can I get a copy of what those were going to be? I just need a list of the bills that we're going to hear today. No worries, thanks. Which of these are the 345? And 1213? Do you want to just present together? Sure. Okay, all right. Do we see, Travis is here. Okay, great. All right, we're going to hear Senator Fitzwater's 1178 and Senator Nicola's 1213. If you want to present together, then begin when you're ready. It's okay. I just need to know which ones we're going to.
Thank you, Madam Chair. Senator Travis Fitzwater, 10th Senate District. Glad to be here in front of you and members of the committee. And glad to be sitting next to Senator Nicola on, I believe our bills are identical. And, you know, as I was thinking about my legislative agenda, I thought, how could I more efficiently and sufficiently annoy more people in the building? So I filed this bill and accomplished that goal. So here we are. But I think this is pretty simple in my mind. Everybody says theirs are simple. This one's simple. I've talked about transparency in healthcare for a while. This is doing that. And so the desire here with Senate Bill 1178 is to take the 340B program, which is kind of a complicated pharmacy program, to how we reimburse pharmacies through hospitals in high need areas, areas that have some need some help in investing in the high risk needs of their communities. And it just says, listen, it's a proliferating program. Let's just make sure that we have aggregate data and transparency on where those dollars are going, where they're coming from. So it's a private program. The hospitals have to just aggregate their data and say, this is where we're getting discounts, this is where we're expending dollars, this is where we're sending those dollars that we're attaining on drug costs, and this is where we're putting them. So, I don't think transparency is a bad thing. That's the genesis of this. I think as our healthcare program grows and expands, this is one way we can look at the federal program and say, how do we save money in DC? This is one way to look at that and say, okay, are we doing this right? Is the expansion of this going the way we want it to go? And it's not sharing individual patients' information. It's aggregating that information and making sure that it's going to where it should go. Because the federal government basically trusts the system to take the dollars and put it into these high need areas that they see as an issue, rural areas where low income folks need care. These dollars, these discounts are intended to go to those focal points. So just want to make sure that's actually happening. I don't think that's, as we aggregate data, it's hard for the state to look at that and say, are we doing what this program intends to do? So that's, I think, a high-level view of it. I'm happy to answer any questions, and otherwise I'll hand it over to Senator Nicola. But I think it's pretty simple. Transparency is a good thing.
Thank you, Senator.
Thank you, Madam Chair. For the record, Senator Joe Nicola, District 11, which I serve the northeast corner of Jackson County. I don't have a lot more to add to what Senator Fitzwater had to say. Glad he filed it as well. Be honored to sit next to him today on this. It's really simply a transparency bill, so we would know where the dollars, how many dollars are coming in, where the dollars are being spent. The data that I have seen, that it's costing millions of dollars to employees, employers, and even the state. This whole program has just really ballooned, and I think the legislature, we need to know where the money's being spent, how it's being spent, and making sure From what I understand, even on a federal level, the program's really not as clear and defined, and I believe they're working on that on a federal level of what can these dollars be spent on. And I just think it's good government that we are able to see, put some light on it and see where are these dollars being spent. I think all of us, I'm going to assume anyway, want to cut healthcare costs, and this could be a major way to do that. So with that, I'd be happy to answer any questions as well.
Are there any questions for the senators? Senator Bratton?
Well, thank you guys for bringing this forward. I mean, transparency is one of those things. I mean, back when I was in the House, tried to get through. I know we've gotten incrementalism when it comes to transparency. Former colleague, but now Congressman and Chairman of Ways and Means, Jason Smith. I mean, he's had a lot of these guys in front of him on healthcare costs, and he did had a panel in front of him where he asked, like, who owns a PBM here? Who's owns an insurance company here? Who, and went down the list of what everybody thinks is competing interests. And amazingly, all the same people continue to raise their hand. It's like, so it's just like almost like it's just a game, and everybody, the taxpayers and the people who are trying to get those benefits and trying to get health care are the ones paying the piper. And there's no transparency and there's no capability, and it's just unreal. So I hate the fact that we have to continue to beat this drum of transparency, but I know our federal contingents are attempting to try to do that, but thank you guys for being willing to do this as well. Even if it is a small step, it's at least a small step in the right direction. So appreciate you guys.
Thank you. Any other questions for the senators? Seeing none, I do have one question just before you go. I'm trying to understand the 340B program. I know it seems to be a critical program for a lot of our critical access hospitals. And I'm curious about the lawsuits that were filed by the pharmaceutical companies in regards to the 340B program when a law was passed a couple of years ago. And basically they were saying that the state doesn't have any oversight over the 340B program, but it seems like we're passing more rules and regs in regards to the 340B program. So I'm just curious about that. Anybody, if anybody in the audience could talk to us about that, I'd appreciate it. I am all about transparency. I think all of us are, but I want to make sure that we're getting the whole picture and looking at it from a holistic point of view. It seems like to me that they can, as I was told, and again, I appreciate these conversations and dialogues so that we can come to the reality of what really is going on. But I understand that the HRSA is able to audit the hospitals for transparency at any time. And so are we not getting access to those audits? That's something I would like to know and understand, because if those audits are happening 10 to 1, 10 times more at the critical care hospitals than they are, for the pharma companies, then I want to understand why is it that we don't have access to those audits, or do we, and where are they? And so just some questions that I have as we move forward. But thank you so much for bringing this forward.
Absolutely.
Appreciate it.
Happy to do it.
How many people are here to testify in favor? Okay. How many are here to testify in opposition? Okay. We're going to go with those who are here in favor first, and we're going to limit testimony to 3 minutes.
And just wanted to remind everybody, with two bills being presented at the same time, make sure you fill out separate witness forms for them. So one for 1178 and one for 1213. Thank you.
All right. First person to testify in favor. Begin when you're ready.
Members of the committee, Anne Murray with Bristol Myers Squibb.
I love your
And-
name.
Well, thank you. Appreciate this opportunity to express the company's support for both bills before you right now. As a research-based U.S. pharmaceutical manufacturer, we're committed to delivering innovative medicines for patients with cancer, immune disorders, and other serious diseases, and believe that transparency is essential to ensuring that this 340B program serves its intended purpose to stretch scarce resources as far as possible, reaching more eligible patients and providing more comprehensive services. In 2025 alone, Bristol-Myers Squibb provided more than $175 million in 340B discounts to entities in Missouri, an increase of more than 45% over the prior year, 2024. Those dollars overwhelmingly flowed to large health systems, 97% of that $175 million, with just 3% to rural clinics or small safety net providers. And this experience serves to highlight how today's 340B program has evolved into a revenue platform for major health systems rather than a program with transparency, accountability, or with direct benefit for vulnerable patients, which is why we appreciate the bills that you've brought before you today. Missouri is not an outlier. This state's experience reflects what's happening nationally. And across the country, 340B has exploded in size. You've heard much of that information, I'm sure, from folks who have been in your office before today. Missouri has about 4,500 contract pharmacy arrangements, nearly half with pharmacies outside the state, and only 12% of in-state 340B contract pharmacies are in lower income areas. 36 are in rural areas, even though 52% of Missouri zip codes are considered to be rural. Since 2015, speaking about the audit question, since 2015, well, between 2015 and 2023, the government has conducted only 55 audits of Missouri's covered entities, with more than half of those audits finding irregularities.
Can I pause you
or
right there and
violations.
just ask a clarifying question?
Yeah.
When you say they, the audits, who's?
HRSA.
Okay,
HRSA.
so the federal
HRSA,
level.
yeah.
Okay, thank
And
you.
that process is pretty complicated in the sense that a manufacturer or another entity can request an audit of HRSA, but then there's a pre-audit process that goes on, that takes place before it's determined whether or not the audit will actually happen.
Okay. I didn't mean to interrupt your testimony. We
No.
didn't take away for that
No, that's
time.
okay.
Go ahead.
That's all right. It was an important question, I think, to point out the fact that with how many thousands of covered entities in the last 12 years, 55 have actually been audited, with half of them finding irregularities. So 11 states have now acted some form of 340B transparency and reporting laws designed to help policymakers understand the scale of activity. And as with these bills before you today, the laws generally require the covered entities to report on an annual basis aggregated acquisition costs, aggregated payments received, aggregated payments to contract pharmacies, numbers of claims, and require the Department of Health to hold the data as closed records, and the bills do not require or even contemplate reporting of patient-related data.
If you wouldn't mind, we'll get a copy of your testimony
Yes.
and disperse it among the committee members. So I
Yes,
appreciate your
absolutely.
time. Thank you.
Okay.
Any questions for the witness? I do have one question. Would you say that it's the fault of HRSA for not having more audits? Then, like, who's responsible for not having more thorough audits if the fault is with auditing?
I believe that the department, HRSA, is potentially understaffed, perhaps, doesn't have the adequate resource to actually perform enough of the audits, certainly that are being requested.
Okay, I appreciate that. And the 340B program was something that was set up under Congress, wasn't it?
It was codified, yes, but long before 1992, when it was actually statutorily codified at the time of the Medicaid rebate program coming to be, manufacturers actually provided these discounts voluntarily.
For what? For what?
For
purpose?
disproportionate share hospitals, to make sure that entities that actually served a disproportionate share of the uninsured or perhaps underinsured would actually have access to our life-saving medications. And so it was a program that we actually participated in voluntarily and was only codified after the Medicaid program and the best price rebate situation was codified, which basically requires, like in Medicaid, that manufacturers give the best price of anybody in the country to the Medicaid program. And there was some concern that, of course, if in fact we were offering these 340B discounts, that could trigger best price. And so both programs were codified in statute to,
Because they were-
to clarify that we can provide these discounts in 340B and not impact or trigger, best price, or not impact the Medicaid best price program. So
Did it have anything to do with marketing? As far as what you were giving at a discounted rate prior to the 340B program?
did it have anything to do with
Yeah,
marketing as far as, well, ensuring that patients could get
Access
their
to-
hands on our medications?
Yeah.
I suppose it could be characterized as that, but the interest obviously is making sure that patients got the drugs that we were producing.
Okay, no, I appreciate it.
Yeah.
Thank you. Senator Bratton?
One thing that's always brought up, you said you represent pharmaceuticals. How much money is being spent on advertising? Because this is one thing that really we continue to come down here and say we got to lower costs, yet then I see the billions of dollars in advertisement for drugs that I can't go and buy them. Like, why are we advertising all these drugs that this isn't Mexico? I can't go and literally go over the counter and purchase these drugs. I have to then, so to me, it's just it makes literally no sense why pharmaceuticals are going and selling to the public something that the public cannot access. They have to go to a prescriber. Mm-hmm. I'm not a medical professional, so I can watch that. This will help my tear ducts, from overproducing tears, but you may die and you'll, all these ailments that. But if you don't suffer from those, boy, you won't have, overactive tear ducts. I'm just saying. But if we're looking at how we're going to reduce costs, why are we spending such an egregious amount of money in advertising for something, again, that the public can't go and access?
And I understand that frustration. The public, obviously, in terms of educating the public as far as what's available, many people won't seek medical care if they don't realize there's actually a treatment for their ailment. And so from the standpoint of actually being able to provide information to the public about what is available, what is out there, it stands to educate the public better to then go to a provider and discuss that treatment or discuss that disease with the provider. And I think you've seen an increase in the amount of direct-to-consumer advertising as it's been even more difficult for manufacturers to actually access providers. So from the standpoint of actually being able to go and discuss with them what a particular product could do for their patient population, as that access has perhaps diminished a little bit with regard to how often or how many manufacturers can actually get in to see a provider on a regular basis, if they even have time to see a manufacturer with regard to what product happens to be out there, that it's another way to make sure that the public is aware of what is actually available.
Kind of
for their
sounds like
benefit.
WebMD, though. Because I can go on there and I have a headache and it'll tell me I either have terminal brain cancer or something like that, and then I just go to a. I'm not trying to be facetious,
No,
but it's at the same time.
I
It's
understand
so.
the frustration.
you
Yeah,
know,
I think from a consumer education standpoint, I think that's. I won't speak for other companies certainly, but from a consumer education standpoint, making sure that people are aware
Yeah.
of what's available is a critical piece of it.
So can I ask who you represent? Is it,
I'm employed by Bristol Myers Squibb.
so is that a pharmaceutical
A
company?
pharmaceutical manufacturer based in Princeton, New Jersey, yes.
Okay, thank you. And so I guess as you were talking, I have this question. The pharmaceutical companies are the ones who provide the 340B program, right? Like they're the
Provide
ones
the-
who distribute.
Provide the discounts,
Mhm,
yes.
Provide the discounts.
Yes.
So are you telling me that the pharmaceuticals don't know how much money they're spending in the 340B program?
Well, as I shared with you, I can tell you what we spent in 2025. What we don't have a clear access or clear line of sight into is whether or not those dollars are actually being utilized for the intent of the program in general, or the initial intent of the program, and that is to ensure that those resources are being stretched as far as possible, and that vulnerable patients are getting more comprehensive services.
So this transparency piece basically will ask for what information in aggregate, because it seems, again, so I'm learning, but if you're the one who's sending out the prescriptions for the 340B program, if you're the one participating and providing the medications for the 340B program, it seems ironic to me that you don't have the information to know where that money or those dollars are going. Because aren't
We know
you
where our
sending them-
discount dollars are going because we're paying them to covered entities. So that's,
Right.
that's the amount of money that I was just reporting to you.
Right.
What the entity does with the margin between what they pay for the drug and what they get reimbursed from the ultimate payer, the insurer, what they're doing with that margin is what this bill is trying to actually shed the light on. So they're buy low, sell high effectively. And what's happening with the dollars in between is what this bill is trying, or these bills are trying to shine a light on.
Let me just, this is just really ironic to me. We've been in the PBM fight for I don't know how many years, and we're talking about transparency with PBMs, and we have a difficult time getting transparency in regards to money for PBMs and pharmacies. But it seems like now you're arguing, the pharmaceutical companies are arguing for transparency for 340B programs when they're the ones providing medications to the 340B program. And we'll hash out some more
Okay.
of this. Hopefully we'll get some more feedback with testimony, but I appreciate your time. Any questions for the witness? Seeing none, thank you.
Thank
Appreciate
you.
your time. Next in favor?
Madam Chair, members of the committee. My name is Kelly Gillespie. I serve as Executive Director of Missouri Biotechnology Association. For those of you not familiar with that,
Can you turn your mic on and
I sure will.
make sure that everybody can
Here's
hear?
a green light right here.
Perfect.
Okay. Kelly Gillespie with the Missouri Biotechnology Association. For explanation purposes, we are the state's life sciences organization, and we have a range of company members that are involved in human health, plant sciences, animal health, biofuels, really ranging from research to commercialization. And oftentimes we're involved in economic development for the state of Missouri. We're trying to get that onshoring that has escaped overseas in the last generation to relocate and find a place here in the heartland, here in the Midwest, and have a business attractive environment to do so. This type of bill, both of these bills, take a step towards giving you all as policymakers a little bit more data. This is complex business marketplace, as you've mentioned. We are trying to get control of all the necessary big money elements that ultimately hit our consumers, hit our constituents, our citizens. If you're a researcher and you've dedicated your life to pneumococcal pneumonia or whatever else you're hearing advertised, you just want to get it to the patient. But ultimately, it is the Wild Wild West, and this is the free marketplace, and people are able to make some money through the health reimbursements. But that is the engine that is our social contract that allows new products to come, new innovative products, and hopefully they're being innovated here in the United States of America, and that we don't lose that biotechnology edge to other places. So this bill starts, these two bills start to provide some of that data. I noticed a couple years ago when the legislature was wrestling with 340B, we had fiscal notes, but we didn't really have a true market analysis of what it was going to cost the major players. And I think that is one of those things that helps business people to understand whether a state has their act together, whether the state is willy-nilly changing policy for politics versus really trying to get down deep and understand that. There are no bad players here. There's no silver bullet to it. We're just trying to say with that, we use the word transparency. But the long and short is we're trying to get better data for policymakers for the state of Missouri, which is a major purchaser, and that's what the end goal is. Happy to answer any questions.
So I'll ask you the same question. Do you believe the state legislature has oversight on the 340B program, or do we not? Should we be passing laws regulating the 340B program, or should we not?
You know what? The cattle's left the pen. I mean, there's 10, 12 states that are going. Missouri was one of the early ones, and I took the
there's
tack.
lawsuits filed against us because of it.
That's right, and I took
So
the
I'm
tack. I took the tack 2 years ago and said, you know, are we ready for this? And do we know what impact we're going to have, and have we dialed this in right? A lot of times, legislation will take several years and a complex aspect.
So again, I'm just gonna, this is where I'm at, and so help me fill in those deficits. But what I see is the pharmaceutical companies there was a lawsuit, you didn't want transparency, or you didn't want to participate in the 340B program to be, we passed that law a couple of years ago, regulating some of the 340B program. The pharmaceutical companies came back and said, we don't think it's the state's prerogative to regulate any of the 340B programs. So there were 4 lawsuits filed against Andrew Bailey in regards to the law that we passed 2 years ago. And now you're coming back and saying you want more transparency over the 340B bill, over the regulation of the 340B program.
Senator, my organization was not part of any of those 4 lawsuits.
Okay.
And again, we represent the broader ecosystem. That involves research institutions, hospitals. We're trying to ask you to get it right for the entire system. And, you know, so I'm not a subject matter expert on that litigation and not prepared to answer. I'm sorry.
No, and
Happy
again,
to
I'm not
explore it with you
either,
afterwards.
but it's just curious to me that,
Sure.
that the same entities that are pushing back on transparency in other regards are now coming back and saying they want transparency when they're the ones that are initiating the program. They're the ones who are basically disseminating their product, right, to the hospitals. So
if I had an opportunity to figure out who those 4 companies were and send them to your office, I would be highly encouraging them to do so. So you
Well,
can
I
have
hope-
that discussion and learn.
I don't want to browbeat. That's
No,
not my
no.
intent.
I know you're not.
I don't know what you know, what you don't, and so I'm just
Yeah.
basically putting my thoughts out there. So I appreciate your time. Thank you. Any questions for the witness?
Good morning.
Good morning.
I think you mentioned there's 11 other states that have similar language. Is it identical to the 2 bills that we see in front of us today?
I think Indiana is from my personal research, Indiana looks to be the closest to Senator Nicola's and Senator Fitzwater's bill, but there are, each state takes a different twist on it, so.
Well, sometimes we often like to see other examples of how it's worked or not worked. So, in Indiana, you said is similar?
I would, and I'd be asking someone else that's a higher subject matter expert than me. I'd ask, has ALEC spoken on this? Have they vetted it? Have they put it out there as model language? I'm unaware, so I'm just making a suggestion.
Okay. Is the other subject matters expert
I bet
in the
Ann
room?
Murray, who was your first witness, probably has
Okay.
some of those because she watches the rest of the state.
She's nodding, so I
Okay.
can follow up. Thanks.
Thank you. Any other questions for the witness? Seeing none, we do appreciate your time.
Thank you,
Thank you. We're going to switch things up just a little bit, and I'm going to ask for testimony in opposition, and then we'll rotate back and forth. First, witness in opposition. Are we still at 2 minutes? Doing 2? Yep, 2 minutes.
Madam Chair, members of the committee, Rob Monsess with the Missouri Hospital Association. And I'll have to fill out another form for both those. So I'm going to provide a little transparency. What this bill is about it's about money. It's about the drug companies being upset that they have lost a battle in Congress about taking 7% of all the drugs they take nationwide and providing discounts to providers that are absolutely the difference between life and death for hospitals, FQHCs, all across the state of Missouri. This is about losing a battle 2 years ago on contract pharmacy, which was legislation that was passed by the state of Missouri, that is the law of the land, that many of these companies, including Bristol Myers Squibb, are not complying with the law today. And the result of not complying with that law is costing your constituents, hospitals in your communities, at a minimum, our conservative estimate is $50 million a year. That is the law of the land today. And I'll also point out, and the chair, I think I appreciate you bringing this up, is they are in federal court. They sued Andrew Bailey after the law was passed, a combination of PhRMA, which is the Association for the Drug Companies, and individual drug companies. They have one lawsuit that they filed in the Eastern District Court. They had 3 lawsuits that they filed in the Western District Court. And in court, they are suggesting, to the chair's point, that the state doesn't have the authority to regulate 340B. Yet here they are. I mean, and I have great sympathy for Senator Nicola, Senator Fitzwater, who have been hounded on this issue to file legislation, despite the fact that they're in federal court saying the state doesn't have authority. But here they are in front of this committee and petitioning every member of the Senate for the last 2 years, suggesting you do have authority. So which is it? Do they have authority or do they not? What I do know is that the operating margins for the drug companies, and why, Senator Bratton, they can spend billions of dollars on ads, is the average operating margins for the top 5 I have, 28%, 23%, 31%, 21%, 29%, Novartis, Pfizer, Merck, Sanofi, GlaxoSmithKline. The average operating margin for a rural hospital in Missouri is 0.5, and half the hospitals are underwater.
Thank you for your testimony. Any questions for this witness? Senator Lewis?
Good morning. So, I appreciate your comments, and this is a federal program. Are there any audits or reporting requirements that you all are, like, transparency that's around this program?
This program is very highly regulated. And I will tell you, it's so valuable to our members, to the FQHCs that participate in it, because it is the difference between life and death, that they internally audit themselves every year. They can expect a HRSA audit every 4 or 5 years with a focus on policies and procedures, program eligibility documentation, key elements of 340B program operations, virtual inventory management, program universes, database accuracy, 340B eligible prescribers, provider credentialing, purchasing documentation, contract pharmacy documentation, Medicaid duplicate discounts. So, I mean, when they complain about the program growing, that's true. The most recent growth in the program came from every critical access hospital in the state getting access to it, which so they want to complain about the growth of the program. It grew to cover the critical access hospitals, and I would tell you that without 340B, and if left to the devices of the drug companies that continue to undermine the program, half those rural hospitals, critical access hospitals, wouldn't be here today. And many of them, even with 340B, are barely surviving. And yet the drug companies are 20+% operating margins, including carrying this expanded burden of the 340B program. I mean, these numbers are from 2026. She was quoting, the Bristol Myers Squibb person was quoting numbers from 2025. So they're still making 20% margins and paying for 340B. They can afford it. The Congress understood that. The Congress still understands that. We're hopeful the court understands that and will uphold the law that was passed by the Missouri legislature, that they are not honoring today. They're not following the law today.
Right. And I appreciate the information, the one-pager, and then just want to share with the committee. I'm can follow up with it, that I received an email, and I don't know if it's been distributed, by Will Franklin, who is the CEO of KC Care, which is a FQHC in my district, that this is a lifesaver program. So I think that, we have 20 plus rural hospitals that have closed over the past decade. We can't afford to lose any more in rural or in the cities.
I totally agree with you, Senator. I appreciate you saying that. I would tell you that in other states where they have passed this, the drug companies, using all the same kind of money that they use to advertise, they use this information to weaponize it and undermine the program that is so valuable to keeping the healthcare infrastructure in those states. They're just trying to undermine the program. And they have unlimited money to do that, it seems.
Thank you.
So I have a question. Did somebody force or compel them to participate in the 340B program that was set up and designed by Congress?
So my understanding is that the program is voluntary, but if they want to sell their pharmaceutical drugs to the government, they have to participate.
So they could choose not to participate in the 340B program?
That's my understanding. I could be wrong on that, but that's my understanding.
Right. Okay, I appreciate that. Thank you. Any other questions for the witness? Seeing none. Appreciate your testimony. Next, in favor? He's in opposition. We're doing favor. Mhm.
Good morning, Madam Chair.
Good morning.
Vice Chair, members of the committee. For the record, my name is Calvin Pugh, and I serve as the 340B Policy Director for Community Access National Network. I have called Kansas City my home since I was 4 years old, and I am the living, breathing manifestation of the 340B program working as it should. I respectfully come before you to ask for your support in this, for both these bills. When I was diagnosed HIV positive 10 years ago, at 28 years old, I had little engagement with the healthcare system. Suddenly, having to take a medication every day that costs $117 while making $60 a day before taxes is unreachable. But thanks to the 340B program and its participation in the state's Ryan White AIDS Drug Assistance Program, I was afforded medication. That program has been a rebate model, I might add, since its inception. The program provided me with social services, medication guidance, and as a result of this program, working as it was legislatively intended, I'm here today. The AIDS Drug Assistance Program is mandated by the Ryan White program, not 340B, to ensure that every dollar spent reaches eligible patients and provides more comprehensive services. Some grantees, like my former employer, KC Care, are also dedicated to that mission, provide transparency and ensure that patients in my neighborhood get dental care. That mission-oriented commitment cannot be said for large hospital systems today. They are buying Super Bowl commercials, paying their football coaches, the naming rights to football stadiums, while providing historically low charity care and claiming non-compensated care while sending patients into aggressive debt collections. If I may be frank, I'm not dumb enough to believe that art, a fountain, or a CEO's salary increase reaches more patients or provides more comprehensive services. The flaws in this program are well documented. In the CBO report recently, the agency identified how the program incentivized bad behavior such as hospital and clinic consolidation, rural and privately owned pharmacy chain being bought out by pharmacy chains, and has grown to become the second largest drug discount program in the nation. We, us patients, ask, what do the margin motivations of large hospital systems, pharmacy benefit managers, for-profit chain pharmacies, and their third-party administrators do to help the Missouri farmer who needs heart medication? What do they do to the Missouri teacher whose child needs cancer treatment? These are my neighbors. I benefited from this program. So should they. But between these expensive healthcare premiums, rising hospital costs, PBMs, third-party administrators, adding the hands to the 340B cookie jar, healthcare is out of reach for my neighbors.
Thank you for your testimony.
Absolutely.
Appreciate it. Any questions for this witness? Seeing none, appreciate your time. Thank you. Next in opposition.
going to fill one of these out real quick.
You can take it to you with you and just leave it
Thank
on the
you.
table when you're done.
Okay.
Thanks.
This is my second time doing this, so I will be using notes.
Yeah, you're good.
Chair and members of the committee, thank you for the opportunity to speak today in opposition of Senate Bill 1213 and Senate Bill 1178. My name is Dr. Anna Dale. I'm the pharmacist and director of pharmacy for Katy Trail Community Health Center and FQHC. We serve patients across Pettis, Saline, Morgan, Benton, and Johnson County. Many of you will know that these are very much rural areas and they're medically underserved areas. I would like to start by answering some of the questions that many of you have already posed to individuals that have sat in this chair, and that's by creating the framework of 340B. 340B was established by Congress. The program, in my perspective, intentionally creates a symbiotic relationship. Manufacturers voluntarily choose to participate by requesting and gaining approval for Medicaid drug formularies. Manufacturers are granted access to a larger profit pool to continue driving the innovation that has previously been discussed by the manufacturer representatives that sat here. As an obligation of that voluntary participation, manufacturers are required to provide discounted medications to health centers like ours. This allows our safety net providers to remove barriers to care and to directly reinvest in improving health outcomes for our most vulnerable patients. In our communities, the ones that we serve at Katy Trail, patients often travel 20 to 40 miles at minimum to access our services. And the revenue that we generate through 340B allows us to remove those barriers, often ones that extend far beyond a physical exam and often into transportation needs. Additionally, we have initiated a hepatitis C program, and in the 2 years that we have had it in our rural areas, have cured more than 20 patients in 2 years through simplified treatment guidelines. Without 340B support, many of these individuals would not be tested. They could not afford medications. I think the last copay that we were able to provide to coverage to a patient for was about $9,000. So that's pretty significant. Nobody would be able to afford that in most scenarios. So again, without 340B support, many of these individuals would not be tested. They could not afford medications, or they would face month-long delays waiting for specialty care. We also employ a clinical pharmacist who manages our chronic metabolic conditions like diabetes. She provides education, she provides medication monitoring and frequent follow-ups that help prevent long-term complications and reduce avoidable costs to an already strained healthcare system. This care directly aligns with keeping America healthy. One life alone who has been changed by this program has gone from an A1C of 13 to 6.5 in a matter of months because of added layer to care, and her quality of life is night and day. These examples reflect the work.
I need to stop you right there just to be fair to everybody else.
Yeah.
So any questions for this witness? Seeing none. I appreciate your time.
Thank you.
Thank you. Next. In opposition?
Madam Chair, members of the committee, Jorgen Schlammer on behalf of Missouri Primary Care Association and also Freeman Hospital in Joplin. I'm not going to be redundant of all the comments that you heard. I think one of the items was the participation of manufacturers in the 340B program. The trade-off, the program's inception really became when the manufacturers went to Congress and said, hey, we need protection on exactly how deep of a rebate will we have to give to Medicaid and Medicare. And in exchange, Congress said, fair enough, because you can only drive down the price, according to Congress, you can only drive that price down so far in the Medicaid program. But Congress then said, if you're going to get that protection, then you have to provide some discounts in the 340B program. I don't know if it was the intent of other witnesses, but the growth of the program is not controlled by the provider. It's like saying, wow, why is this Medicare program growing so fast? Providers, what are you doing? Providers don't make people more or less eligible for the 340B program. That is set in Congress by law, and those folks are either eligible or not. A provider, a hospital, an FQHC, a Ryan White clinic, a kidney dialysis unit, those folks don't make people more or less eligible for a 340B. That's established by Congress. You either meet the eligibility or you don't. And if you do, then you have to, and remember, the 340B is on the back end. So we don't claim a 340B transaction. What we do is we pay full price for the drug, and then after the fact, we get a rebate. Or actually, we don't even get a rebate. We get a discount on replacing that drug in our inventory. The bill talks about payments from 340B covered entities to pharmacies. They don't pay pharmacies. Pharmacies get paid from third-party payers or the patient. There isn't, I mean, maybe I can be corrected. Maybe the hospital pays its in-house pharmacy, I guess. But as far as a contract pharmacy, we don't get payments from 340B providers. So I'm a little unclear on some of the language that they're reporting, that they want reported in the bill. And finally, HRSA does make all the audits on their website publicly available. And if there's some, other information that they think is not included in there, we'd be, happy to know that. But they definitely audit us to ensure compliance that the money's spent correctly. So thank you,
Okay, appreciate
Madam
it.
Chair. Yeah.
Any questions for the witness? Seeing none.
Thank you.
Appreciate it. Next in, are you in favor? Are you opposed?
Opposed.
Come on up.
Good morning, members. Good morning, members of the committee, Madam Chair. My name is Alex Tuttle. For the record, I'm here on behalf of the University of Health, Kansas City, Golden Valley Memorial Hospital, and Hannibal Regional Healthcare System. Want to go on record in opposition to these bills. Can't add a lot, but I do want to talk a little bit about transparency. To the first witness's point where she remarked that only 2% of these savings went to rural hospitals, I have examples where Bristol-Myers is not currently in compliance, and since April 2025, one of the hospitals in opposition, it's cost nearly over $600,000 April 2025 till now. So if they were in compliance, possibly more savings could be passed down to rural hospitals.
Thank you. Any questions for the witness? Seeing none, appreciate testimony. We're going to do next in favor. Anybody else in favor? All right, next in opposition.
Thank you, Madam Chair, members of the committee. Justin Alferman representing SSM Health. Not to be redundant, I agree with pretty much all the testimony that came before me, but I do want to speak again against, or kind of talk about the audit process. I think Mr. Schleiermeyer said it perfectly. All of these audits are, if you type in on Google and you just type in HRSA, Program Integrity 340B, you can see all of the audits that the HRSA does every year. So to say that hospitals or 340B eligible entities are not being transparent when we are fully complying with the federal program, you can go there and look at everything. We are audited routinely. And I would also call into question the 55 number, because I know that just my hospital system, and we own 9 hospitals in the state of Missouri, we've had 8 audits in the last 10 years. So I don't know where that number comes from, but I find it hard to believe that my hospital alone is 10% of all audits during that time.
Thank you.
Be happy to answer any questions.
All right. Can I ask a couple questions for you? What can trigger an audit? Can they trigger or ask for an audit at any time?
Yes.
So
HRSA can do an audit anytime they want. They are not on a schedule. They can, oftentimes a complaint can be filed and HRSA can investigate. And then there are internal schedules that they go and audit periodically.
So your argument,
and I want to be clear that not all of my hospitals, we have 9 hospitals in the state of Missouri, not all of them are 340B eligible based upon payer mix.
and so you're saying that the audits can happen at any time, And that those audits are published on the HRSA
Yes.
website?
Yes, and we are always worried about 340B compliance in the event that HRSA will give us a call and say, guess what, you're under an audit.
Do you also understand that the pharmaceuticals agreed to participate in the 340B program? Is that your understanding as well?
That is absolutely correct.
So they can participate in the Medicaid and Medicare?
If they want to participate in Medicare and Medicaid, correct.
Okay. Thank you. Appreciate it. Any questions for the witness? Seeing none, thank you. Next in opposition.
I know we're running short on time, so I will be super quick. Tom Greenlee, Senior Director of Pharmacy Services for MU Healthcare. We do support transparency, but we do oppose these two bills. At the heart of the transparency debate is basically two fundamental questions. One, how much benefit are covered entities receiving? And two, how are those entities using that benefit? As to that first question of how much benefit we receive, MU Healthcare has always been very transparent with that. We do publish our benefit information on our public-facing website. We also publish our uncompensated care, our charity care numbers are also out there for public consumption. We also submit data to the Missouri Hospital Association that aggregates a lot of that same information that's being asked for in this bill, and they already make that information public. So a little bit of redundancy as far as that goes. In terms of us complying with this bill, we figure and calculate about $250,000 a year in annual costs to comply with this legislation. That's a combination of hiring additional FTEs, diverting people from current work, and then hiring external consultants. In order to put a report like this together and aggregate a number, it's pouring through millions of lines of data. That's not something that can be done really quickly. So not only do we object to the administrative burden and the cost, we also object to the timing that is played out in this bill, asking us to have this report ready and submitted to the state in only 90 days after the end of the calendar year is also very burdensome from an administrative perspective. So I just want to say that MU Healthcare obviously has a very important mission in terms of supporting rural healthcare. To the earlier witness's point about sort of the disparity between where the 340B benefit in Missouri is and it being concentrated in more urban areas and not in the rural communities. The data is probably being pulled based upon the address of the covered entity. So in the case of MU Healthcare, that's probably Columbia. Where are we at? We're also in Fulton, Mexico, Callaway County. We're in Boonville, Eldon, Versailles, Owensville, et cetera. So that benefit is being given to those communities. However, our covered entity is probably going to show all that in Columbia. So there's a little bit of misleading to that data as well. So with that, I'll pause. I live in the 340B program every day, and I'm happy to answer any program questions.
I appreciate your testimony. I have a question in regards to, is it your understanding that do your hospitals pay for the pharmaceutical and then get reimbursed through the 340B program?
Yeah, so it's a little bit different in every setting. So what Jorgen said is correct in that we pay for the first drug at full price, and then for future replenishments, based upon whether or not we have enough 340B eligible claims in our history, we can purchase future purchases at that discounted price.
Okay.
So we do have to purchase upfront that first purchase at the full price in order to make that virtual inventory program work.
But not every script and then get reimbursed?
Not every prescription. I think you'd probably be surprised to find out, like in our own in-house pharmacies, our own MU Healthcare pharmacies, we only have about 60 to 70% of the prescriptions we fill are even 340B eligible. So I also want to clarify, like this isn't every single prescription we're filling, every single drug we administer. There are eligibility criteria that have to be met before those claims are deemed eligible.
So from your perspective, what's the benefit? Why the urgency in trying to pass the transparency bill then?
I think they're trying to strike while the iron's hot. There's been some transparency bills passed in other states, such as Minnesota, for example. They were the first state to pass a transparency bill. They've already published their annual 340B reports. Didn't take long after that report was made public that opponents of the program were certainly attacking the covered entities there in Minnesota. So these are the covered entities that are providing safety net health care throughout the state. They became, kind of the recipient of a lot of negative publicity directed at them from the pharmaceutical manufacturer. So I think they're trying to strike while the iron's hot. A lot of states are starting to pass this. There's some momentum for these kinds of pieces of legislation. I don't think there's a sense of urgency in that a lot of covered entities are already making this information public, whether it be through their trade associations or their own public-facing website. So I don't really understand the sense of urgency. I don't think you all need to feel a sense of urgency in this regard, but just know that I think they're trying to just take advantage of some national momentum.
I would just like some clarity personally on whether or not the state has jurisdiction over the issue.
That is a fantastic question.
All right, thank you.
And to speak, I would probably be hypocritical if I came up here, right, because we supported the contract pharmacy bill a few years ago, and here I'm in opposition. So I think just based upon the contrasting nature of these bills, all of us probably are going to be a little bit of a victim to playing both sides of this discussion.
Appreciate it. All right, Senator Lewis.
Good morning.
Yeah.
As far as Minnesota, like you said, the hospitals were targeted. Can
Yeah.
you further elaborate on that?
Yeah, I would love. Yeah, if you want to, I'll share the blog post. So one of the actually was Pharma Senior Director of Public Relations. Just a few days after would be a great example. He put a blog post out there that attacked Minnesota covered entities, basically taking the data that was aggregated in terms of the overall benefit that was received, but then just cherry picking a few elements of how the benefit is used. And that's really the crux of the problem with these kinds of bills, is they're asking for us to aggregate all of the data in terms of what we're receiving for benefit, but then only asking the state to aggregate certain subsections of the benefit that we're giving to our communities. So it's naturally going to paint a very unbalanced picture of the 340B program. So again, those attacks on those Minnesota covered entities came very quickly after the publication of that report.
Right, thank you.
Great. Thank you for your
Thank you.
testimony. Next in opposition. How long do we have the room? Where are we at on time?
Good morning, Tony and Richard. I'm the CEO of HCC Network in Senator Nicola's service area. First, I'd like to apologize for my attire. I did not plan to testify today, but after some questions, I thought it would be in my best interest to make just a few comments. I won't reiterate what's already been said. You keep asking the question about who's responsible for what. This is the easiest way, and let me back up. I've been in my role for almost 20 years. Been running a health center since 2013, so 340B has been a lot of that compliance time. I'm also the president-elect for the National Rural Health Association, which also has taken up very strong positions on 340B. The easiest way to describe the responsibilities of the states for 340B is to talk about distribution. The federal government is responsible for pricing. And so that's just the easiest two buckets to kind of think about. I'd like to echo what a few people have said about Senate Bill 751 and the non-compliance on the monitoring side of that. We can talk about that offline if we need to, but until we get these first pieces of monitoring in place, it's going to be very difficult to ask for additional monitoring. I just ran some quick numbers. Multiple people mentioned the audits. Health centers and critical access, anyone who participates in 340B also typically participates in what is called a 340B mock audit, where we actually pay somebody to come in and say, we're not being audited, but we're asking you to look through all of our stuff. That costs on average $8,000 at time. Most health centers and hospitals will do that every 2 to 3 years, depending upon their volume. HRSA site visits are very invasive. They come to visit all of our sites every 3 years. They inspect governance, finance, clinical expectations, outcomes, et cetera. Currently on a $15 million budget, my organization is paying about $140,000 a year to our audit company to make sure that we are in compliance with all of the federal regulations and making sure that we are training our staff on the newest and latest trends that are happening in health centers. I also want to make a comment that there is currently anti-pickpocketing legislation in about 35 states. I think somebody mentioned eight or 10. It's closer to 35. And the last thing I will say is that OPA is, the Office of Pharmacy Affairs, is what manages the audits and those expectations at the federal level in terms of pricing and utilization.
Thank you for your testimony. Any questions for the witness? Senator Lewis?
Just briefly, anti-pickpocketing, you said it's in 30 plus states?
35. Mm-hmm.
Is it in Missouri?
I'm going to look at it's not, but where'd he go? He left.
There's legislation moving right now in the House and the Senate that has that.
Right. It gets introduced often.
Okay,
But no,
thanks.
it's not current.
Any other questions for the witness? I'll just close with one question, if you don't mind. Do you choose to do the mock audits, and are those published anywhere?
We do choose to do the mock audits. Honestly, nobody's ever asked us to see them. We're happy to share them. I can't speak for the entire industry, but I can speak for our organization.
Just curious about the transparency piece, and if you're
Yep.
choosing to do the mock audits, if it might be helpful,
Yeah.
for more transparency to have those published somewhere.
Sure. Well, and I think a lot of people, I know why people pay to have them done. It's because they want to make sure that they are in compliance, because losing the program would be devastating.
Right, I get it. Thank you. Appreciate it. Next in opposition?
Madam
By
Chairman,
the skin of your teeth.
I'll be very brief. Will Mars on behalf of Mercy Health Systems, just want to go on record in opposition and happy to stick around after to answer any questions.
Thank you. Any questions for the witness? Seeing none, appreciate your time. Is that last call for those in opposition? Okay.
Heidi Lucas, Executive Director of Missouri Rural Health Association. We're against this legislation. Thank you.
Anyone else in opposition? Seeing none, closing comments, Senator Nicola?
Thank you, Madam Chair. Appreciate it. Thank you, committee, for allowing me to present this bill this morning. One thing is for certain, healthcare is messy and it's extremely complicated. And Senator Lewis, I wanted to answer one of your questions. ALEC does have model language for this as well. I've heard the word regulating several times. This bill regulates nothing, according to 340B. It's only transparency, that we have transparency of where the dollars are being spent. And I've had several reports, up to $152 million that it's costing the citizens of Missouri in healthcare costs and other health-related things. So I think as legislators and as the Assembly, we should at least have the right to know if it's costing our citizens money, where the money's being spent. So I just want to reiterate this bill, that it's transparency. It does not regulate 340B. It's not changing anything. I don't even have a desire to do anything like that, but it's just transparency, and we need to see where the dollars are going. That's it. So thank you, Madam Chair. Appreciate it.
Appreciate it. That concludes the hearing on your bill, Senator. Yep, that concludes the hearing for 1178 and 1213. We're going to move to Senator Moon with his Senate Bill 1267. Senator, begin when you're ready.
Good morning, Madam Chair and Committee. I'm Mike Moon. I represent the Missouri 29th Senatorial District. I'm here to present Senate Bill 1267. And just want to continue the conversation of transparency a little bit. And this one particularly has to do with the cost that are associated with hospital and in medical care. You know, when I walk into a store, and I imagine it's the same with each of you, you like to see what the price of the products that you're wanting to purchase are at the time. And that's kind of the way it is with healthcare as well. You want to be able to determine what your cost might be when you agree to a procedure or any type of medical care. Now, for several years, federal law has required hospitals to disclose their prices so patients can understand the cost of care before and after these services are provided. And because there seems to be no meaningful consequences, few comply with the law. Now, there are some who do, but not all. Today, when hospitals fail to comply with federal price transparency requirements, they may receive a warning, may get a little bit of guidance, and they may have an extension of time to comply, but that's it. Meanwhile, patients can still be billed, and usually they are. If they don't pay in a timely manner, they can be sent to collections, they can be sued, and ultimately their credit could be damaged as a result of non-payment, even when the hospital was not transparent about the pricing as required by the law. And this bill doesn't create any new federal standards. It doesn't regulate prices. It doesn't prohibit hospitals from billing for services rendered. What it does, though, is pretty straightforward. You're either compliant or you're not compliant. And so what it does is a hospital is, if a hospital is not materially compliant with existing federal price transparency laws at the time that the care was provided, the hospital may not use the courts, debt collectors, or credit reporting agencies to collect that debt. The hospitals remain free to bill, receive voluntary payment, and to correct compliance issues in the future, but they should not be permitted to leverage the unclear pricing practices while simultaneously using the strongest collection tools available under state law. This legislation aligns incentives. Hospitals that comply with transparency rules are unaffected. Hospitals that do not comply simply lose access to aggressive collection actions for that period of noncompliance. In short, this bill turns price transparency from a paperwork requirement into a real consumer protection without expanding government bureaucracy, without rate setting, and without interfering with patient care. It's about fairness. It's about accountability and enforcing laws already on the books. So transparency without consequences is not transparency. It's a suggestion, and that's exactly what happens. No harm, no foul. They're not going to have anything done to them, so why comply? This bill supplies the consequence. And you will see if you go to different sources that there are hospitals that are completing, as far as compliance, a lot of the objectives, but not completely. If someone told me to drink completely this cup of water and I take a sip, have I complied with the request? Not fully. I either do it or I don't. And so that's what we're asking, is just that this is a consumer protection bill to allow us as consumers to determine what our cost might be for a procedure that we either elect or are asked in our treatment plan to take advantage of. So that in a nutshell is it. If you have questions, I'd be happy to attempt to answer.
Appreciate it, Senator. Thank you. Any questions, Senator Lewis?
Good morning.
Good morning.
I think transparency is the buzzword of the committee today.
Mm-hmm.
And I think, definitely, I think we all agree, despite what side of the aisle, that we need transparency. Our constituents are struggling with access to health care. I think just sometimes it's the way we get there. So my question to you, is this, the bill before us, is it identical to the one we heard last year?
I'm pretty sure it's the same.
Same exact. Okay. I think one of my favorite things, as a senator, is to work with the opposition to see if we can, listen to their changes. And there were several in opposition last year. Have you had the opportunity to chat with them about, some of the changes they want?
Yeah, we're still in some discussions.
Okay.
And we're open to changes if they're not substantively changing the direction we want to go with the bill. And I know you were in the medical community, and I'm understanding that you want to do the best for the patient as well.
Yes,
and that's
absolutely.
what this is aiming to do, is to give them some certainty on what the cost might be. I'll give you an example, if I may.
Sure.
A few years ago, one of my sons had a hand problem. He hit something. I'm not sure what he hit, but anyway, we took him to the doctor. They determined that he had a hairline fracture, and the cost may be between $100 and $400. Would you like to pay today? And I said, well, if I pay the $400 and it's only the $100 in reality, will I get the difference back? And they said no. And I said, well, I don't want to pay anything today. And I didn't. I don't recall what the actual cost was, but that's what we're trying to solve here today, just to say, here's what the cost is, and at least have some certainty that that's the true cost.
Okay, awesome. Thank you. And I'm happy to be part of those conversations as we kind of work through.
I'd like for you to be.
Okay. Thanks, Senator.
You're welcome.
Any other questions for the Senator? Senator Bratton?
I think this gets to the crux of the matter on the cost of things, that we're charging, is the discrepancies that exist. I had, just like you had, I had a visit with a cardiologist and had like an echo and a test that I was supposed to do where I was like a lab rat, where he had my resting heart, and they did tests, and I was supposed to go and again be a hamster in a wheel to increase my heart rate, blah blah blah. Found out I was out of that network, and they were like, well, if this was covered by insurance, this would be about a $4,500 procedure, but if you want to pay out of pocket, it would only be about $1,000. I'm just like, well, this makes no sense. Or if I go get my knee, a MRI on my knee done, and I paid out of pocket, for myself, it would be potentially like $500 for an MRI on my knee. But the insurance is getting charged for that same MRI from that same MRI machine in that same hospital room by the same technician. They'll charge $5,000, $10,000, whatever. And we wonder why these costs are so ridiculously expensive. So I think there has to be, transparency and the potential for, I think that's honestly why we're here, why we're discussing all this transparency stuff, is the discrepancy. How a hospital can potentially charge these, enormous prices. And I get it for, and I've looked up, it's so they can negotiate prices. So they'll shoot out the big number to these insurance companies and whittle it down to whatever they're going to negotiate down to. But at the end of the day, it's a huge disservice and a huge increased cost in the grand scheme of things when we're allowed to do this. I think, we have a lot of, and I guess just be an equal opportunity offender for all industry, I guess. But, when we have, nonprofit hospitals with billions and billions of dollars sitting in funds while, people can't afford the health care and they, are denied care or real true adequate care, paying $150 for an aspirin, in the grand scheme of how all their procedure costs, just, we've got to figure it out. And is the state of Missouri going to be the one doing that? I don't know. I don't think that with all the federal guidelines that allows that. I'm not trying to filibuster here, but I just, there's just so many moving parts with this where we're wanting to take care of people, but in reality, it's like a protectionism of the system to where, we're filling the coffers of every industry imaginable, and it's the end user that's riddled with, $100,000 in medical debt that's non-bankruptable, and they carry this just to be able to live, so I don't know. I don't know what the magic bullet is, but maybe at least exposing the system and the corruption within, I guess, is maybe it. So thank you for at least trying to go down this road. So I think it needs to be done.
Thank you, Senator Bratton. Any other questions for Senator Moon? Seeing none. Anyone here to testify in favor?
Good morning, Madam Chairwoman and committee members. My name is Hampton Williams with the Missouri Insurance Coalition. We're testifying generally in support of the objective of the bill, which again is focused on trying to achieve implementation of a federal program. Several years ago, there were federal price transparencies, guidances issued to both insurers and to hospitals. For the insurance businesses, we are regulated, 6 ways from Sunday, both at the state level for what our products cost, how our price models are built. People know what they're what their monthly premiums are and what they're being charged for. There have been reports out on compliance with this program from the hospital level. I've got some articles which I'll submit to the committee which addresses some of those concerns. But again, one of the things that the articles highlights are the price disparities for similar services within the same regional areas. There was an article focused on New York City, but there were $100,000 disparities between surgeries for the same thing, and consumers need to know those things. It's something that the insurance industry deals with frequently, as far as trying to find what prices are for services that are being provided. It's something that we're cost conscious of, and obviously consumers need to have that similar types of transparency. So we appreciate the goals of this bill. The mechanics of the bill, I think it has a $1,000 penalty for noncompliance. I believe that CMS already has a fine penalty provision. The other mechanic, which has to do with basically allowing for the recipient of a medical bill the ability to go get an injunction against enforcement or like a lien being pursued from that bill, that would be a unique feature that currently wouldn't exist in federal law. So,
Very good. Thank you, Hampton. Any questions for the witness? Seeing none, appreciate your testimony. Next in favor? It's good to see you in favor.
Madam Chair, it's nice to be on the right side of an issue for me today, and it's an unusual spot to be in and testifying in
You're
support
welcome
of
over more
something.
often.
So anyway, Shannon Cooper today representing America's health insurance plans. Just want to go on record in support of the concept that Senator Moon has, and I think as we've heard today through the previous two bills and throughout this session, I think transparency is an issue that vexes all of us, and one Wednesday morning, one side of the healthcare world is all about transparency, and then today, one team doesn't want to have anything to do with it. And I think that is where the problem lies, that, transparency might be fine for two of the three legs of the stool, but not for all three of them. And I think we'll see that today in opposition to this bill. But the fact of the matter is consumers get confused. Consumers want to, at times, know what things are going to cost them, and just to ask for a general breakdown of what those prices are, I don't think it's that difficult. Many of our members have tools online that if you're going in to get something done, that they can calculate that up and give you a general idea of what that is going to be. And then on elective procedures particularly, that helps a lot of folks out make that decision. And Senator Bratton, you pointed out that a lot of times prices are much different in other facilities, and if the consumers are aware of that, then maybe they can make a better choice. And there's probably instances where somebody with an insurance policy could go pay cash for certain services at a lower rate, actually. And you probably won't give me the time to discuss how that works, so I'll just stop right here and answer any questions.
There might be time for that individually in offices. Thank you for your testimony. Appreciate it. Any questions for the witness?
Just to follow up, like my son messed up his thumb, had a football hit and broke his thumb. We have a friend that's a chiropractor, has an x-ray machine. Took him in there, x-rayed it, had numerous x-rays. Well, we had to go to a specialist, and he ended up having to have surgery. But we took the scans of and the guy only charged us like $50 to do all these x-rays. We go to the healthcare facility and give them the scan of the x-rays, and they're like, we won't accept it. We have to do our own. It's like, and they do all the scans and charge, infinitely more expensive to the insurance, and they're the same dang scans that we literally just took right before we came to the hospital.
I bet that broken bone didn't change from
it didn't
one
change
scan
a
to the
single
other.
bit within that drive to the hospital.
Yep.
So it's just like this sort of stuff. It just makes no sense, and we were able to go and actually save the healthcare, expedite the process, because we were able to make that immediate, I guess, diagnosis of a broken thumb, and it was just. It's just stuff like that it makes no rational sense to me, other than a way to get more money,
to generate more revenue. And I always say this: we're not without fault as an industry. And
Sure.
Senator, you're probably in the minority of people who have that ability to understand and try and navigate and get the best treatment for your son, but also try and get it at the most appropriate price out there. And I think what the public is so frustrated with, that the majority of them don't have that ability or the time to navigate this system. And I'll say, again, all three legs of the stool have to take fault in this, but it seems like every week we talk about transparency and one team's for it and the other two are against it. So,
well, when you have, like I do, 5 kids, and these deductibles have reached these enormous costs, well, of course I have to do what I can to make sure that this is really truly rises to the level of me having to go to the hospital to seek treatment, because we realize what the costs will end up being with these sorts of procedures because they're so enormously high.
Right.
So, yeah. Anyway, thank you.
And I can understand, I appreciate, if there's an emergency or something, and you don't always know what that bottom, what that debt is what debt you're incurring simply because it's an emergency situation. But if you are going in for a broken bone or something like that, there should be a little bit.
Yeah, and
more
let's be clear,
flexibility.
we're not saying that, if you need to receive emergency treatment, it ought to be held up till you get a quote on things. We're just saying, and I think the bill makes that clear of what procedures are out there. And it's just to try and shine some light on this for the consumers.
You know who knows how to navigate the health system very well?
Who's that?
The Mennonite and the Amish. I'm just saying, we have plenty in our neighborhood, and I'm telling you, if you have a question about health system, they'll tell you the chiropractor to go to. They'll tell you how to have your baby at the hospital for the cheapest price.
Yep.
So
And
anyway, that's
they're
a
cash pay.
consumer tip there for those 5 people that are listening.
There might
Anyway.
be 6 today.
The Amish aren't.
If you're done with me, Madam Chair, I'll go to the
We're
back
done.
row where I
Thank you.
belong.
Appreciate
Thank
your
you.
testimony. Next, in favor. Is anybody here to testify in opposition? Okay, we'll take one of you. First customer.
That seems very well for me, Senator. Thank you, Madam Chair. Members of the committee, Justin Alferman, once again representing SSM Health. So I'm going to start out by saying that we are 100%, as of today, fully compliant with the federal law. And actually, I love this bill because every year it's my opportunity to come in and say that I believe that SSM Health has one of the most robust transparency programs in the entire state. In fact, by the time I'm done testifying, you can probably even price yourself on a theoretical procedure at one of our 9 hospitals in the state. If you just Google SSM Health transparency price, you can walk through the process. Type in your insurance, type in private pay, doesn't matter, we'll give you the quote, down to the actual facility of which you are looking at. The problem with this bill is that it gives a date and time that says that if we are not in material compliance, that every procedure that happens on that particular day we cannot seek reimbursement on that particular day for any patient. From time to time, hospitals will be going out of compliance for maybe a day or so because the way that this has to be reported, it has to be reported on machine-readable printouts to the federal government that they put into a scanner. The technology that they're using in that instance is so old and so cumbersome that there are times that, doesn't happen a lot, but there are times when we become non-compliant. What this bill would say is that you don't get any excuses for, oops, you know what, there was a clerical mistake, there was an accident. If you're not compliant for that one particular time, everything for my health system is going to be thrown out for that particular day. Now, again, I would be happy to work with the senator on this to find a common ground that we can agree on, but to say that everything has to be thrown out because of a compliance issue or a technology issue just doesn't seem like, and I don't think that's actually the senator's intent either. So I'm just reading it from how I read it. I'm reading it from what is on the page. I believe that that's a problem in the way that it is written, but be happy to answer any questions.
Okay, any questions for the witness? Senator Bratton?
I'm just disappointed you don't have a bow tie on today.
Senator, when I was in the governor's office, the bow ties I was told I can't wear the bow ties anymore. So
That's been lifted.
that has been.
So-
You know what, Senator? Next time I come to this committee, I will wear a bow tie. I'll do it just for you.
Thank you. Thank you for your testimony. Appreciate it. I'm sure Senator Moon, I won't speak for you, but I'm sure he's willing to work with you on some of those issues. No, he's not. Well, there you go. It's official. That'll teach me.
Not without a bow tie.
Next in favor. Anyone here in opposition?
Anybody here listening to the chair?
There is nobody here in favor.
Madam Chair, members of the committee, Rob Monses on behalf of the Missouri Hospital Association. And my comments in this regard are not about Senator Moon. We've had a lot of discussions over the years with Senator Moon about this legislation and with his staff, no doubt about it. But the other people that were up here testifying in favor Okay, I think it's a little disingenuous. They're all for transparency, but are they for transparency with regard to PBMs, which they all own? Senator Bratton mentioned before, Chairman Smith had the CEOs of all the big health carriers that own. You're either a health carrier, you have the insurance company, you have the PBM, you have the specialty clinics, you have all these complicated relationships between them. That's one of the really complicated things that healthcare providers deal with on a day in, day out basis. It creates, they create this Byzantine system that providers that are just trying to take care of your constituents, your loved ones, your family members, your neighbors, and the insurance companies are leaning in. And so they come up here and say, we're for transparency on hospitals, but they are in no way in favor of transparency on their activity, okay?
Are you testifying, just for clarity, are you testifying in favor of the bill then?
I am testifying in opposition, but we have offered language to the senator's office to try to clarify what is materially compliant. We think that's a little bit vague. What I'm saying is that the people that were up here testifying in support of this bill are against transparency on them. They're for transparency on hospitals, but against transparency on their activity, which I think is disingenuous. I just wanted the committee to know that. I would say that there have been 27 civil monetary penalties issued nationwide against. There's been a ton of transparency that has been a part of the Trump administration. As I will say that the health carriers, when they talked about insurance, is a part of that discussion at the federal level. We would welcome health insurance being a part of this. We will see if they want that to happen. I'm not saying that has to happen. Obviously, it's Senator Moon's prerogative, but we would welcome that as part of this discussion. But there's 27 civil monetary penalties nationwide. In Missouri, CMS has reviewed 110 hospitals. 50 met the requirements on initial review. 27 were issued warning letters, to the point that Mr. Alferman was making earlier. There's all kinds of little details when the machine-readable format works or doesn't work. So it's very hard to comply with the thousands of pages of regulation. So
Thank you.
Thank you.
We're going to get everybody who's in favor of transparency in one room, and we're going to hash out what the definition of transparency is. Look forward to that meeting so that we can all be on the same page. Appreciate it. Senator Lewis.
I know that buzzer went off, but I would like to hear the rest of your thought about if there was something else with the.
So the other thing I would say is the penalty provision is to get rid of the hospital's ability to collect bad debt. And so that's tough the hospitals are trying to operate a business. They're trying to ultimately take care of your constituents. But if you can't collect money that's owed to the hospital, that's a tough place to be. But we're happy to work with the sponsor on trying to clarify some of the provisions of the bill to get at what I think is the intention.
All right, sounds good. Thank you.
Thank you.
Thank you. Any other questions? Seeing none, appreciate it. Next, in opposition.
Good morning, Madam Chair, members of the committee. Again, my name is Alex Suttle, here on behalf of University Health, Golden Valley, and Hannibal Regional. We're here in opposition to the bill. Don't want to come across as opposed to transparency or not wanting to be accountable. We are currently in compliance with federal law. What this bill currently does is add additional administrative burdens that already exist, which we're already in compliance with.
Thank you. Any questions for the witness? Seeing none, appreciate your time.
Thanks.
Anyone else here to testify in opposition?
Good morning, Madam Chairwoman, members of the committee. Olivia Wilson on behalf of the University of Missouri Healthcare. I will keep it brief. University of Missouri Healthcare complies with all of the federal hospital pricing transparency laws. We have tools available on our website for folks to try to get estimates on what their procedures or surgeries or visits would cost. Good faith estimates are also available to patients prior to their visit or their service. I would echo what the previous witness said. These additional regulations would add a cumbersome burden to the hospital that would ultimately increase costs to patients. You hear every time this committee meets about rising healthcare costs. It is legislation like this that would increase that burden on hospitals and additionally put us in a situation to where if there's an error made within that 24-hour window, like Mr. Alferman mentioned, that we wouldn't be able to collect on debt. Like Rob mentioned, we're a business. We need to be able to collect on debt and operate and get what's owed to us. I'm happy to take any questions.
Thank you, Olivia. Awesome. Any questions? Seeing none, appreciate your time. Thank you. Anyone else here to testify in opposition?
Madam Chair, Will Mars on behalf of Mercy Health System, just want to go on record in opposition. And if there are some areas of transparency related issues that we can work with the senator on, we're happy to do it.
Thank you. Appreciate that. Any questions for the witness? Appreciate it. All right. Anyone else here to testify in opposition? Anyone else here for informational purposes only? Seeing none. Appreciate your time, Senator Moon. Have any closing comments?
Yeah, just to clarify here, material compliance, I think, would be deemed if a hospital post required price information, but the formatting is a little bit off. That's not non-compliance. That's just an error, clerical error perhaps. It could be corrected. And so I think there was concern about that. That's not the issue. So.
Appreciate that.
Okay.
That concludes the hearing for Senator Moon's Senate Bill 1267. At this time, we would ask that Senator Coleman presents her Senate Bill 1187.
Can I co-sponsor your bill? Fantastic.
Begin when you're ready, Senator.
Thank you so much, Madam Chair, members of the committee. Mary Elizabeth Coleman, representing this 22nd Senatorial District, and my bill is pretty simple. It is creating a Class B misdemeanor for the use and intoxication of legal cannabinoid products in public spaces. That is a $1,000 fine and 6 months jail time. Examples of those types of penalties are driving over 20 miles an hour and over the speed limit. We know that. Well, first, we know that exposure to kids of cannabinoids is harmful. We have a lot of bills about that. We know that there's a high risk of that harming kiddos, and there's hardly anywhere you can go that you are not exposed to secondhand smoke since the legalization of marijuana in the state of Missouri. You smell it everywhere. You smell it driving down the street. You smell it at the park. You smell it in courthouses. It's everywhere. We have a similar provision, section 574.075, imposing penalties for drunkenness and drinking in prohibited places, and I think the same rules should apply. Thanks.
Thank you, Senator. Any questions for the senator? I just have one question, wondering if there's similar legislation in other states.
I have no idea. This is something that made me mad, and I filed. I have not looked to see what else and where else other people have experienced this.
No, I'm curious.
Yeah, I'm happy. I'll look at
Colorado or some other states have, and what.
I'll look that up and get back to you, but I have no idea if it's illegal in other places where it has been legalized. I'll find that out.
I appreciate that. And then just trying to understand, how many cases are prosecuted. I'd be curious. So, but anyway, just curious.
Sure.
Thank you. Appreciate it. Anybody here to testify? How many people are here to test in favor of the bill? Anyone here to testify in opposition? Anyone here to testify for informational purposes only? All right. Well, Senator, it looks like you're done.
As a longtime holder of minority opinions, I'm glad to see that not enough other people care about this as much as I do, but we'll see if I can't get some broader support in the building.
I think I was in that seat in your committee a couple days ago. So.
Thank you, Senator.
Appreciate it. All right. That concludes the hearing for Senate Bill 1187, and that also concludes business brought before the Family, Seniors, and Health Committee, and I make a motion that we adjourn. Thank you.